Before we move on to, did you want to say anything else, Paul? We've got one other video just to show you for Natalie, if you come up, because you're going to do the PT. We took the opportunity last week, I think it was, we were doing some filming with one of the medics in Sheffield or something else, and we mentioned to him, Charlie Elliott, Dr. Charlie Elliott, who's a Newcastle lad.
Yeah.
And he just wanted to say something about the value of the transplant games as well. So he's just going to show you that one, and then Natalie, I'll introduce.
17th to the 24th.
Yeah. And the UK ones in Newport are...
Newport coming up.
In July. We'll get you the dates. We'll get those on social media from today. We wanted to leave it till today to announce that we need to make sure the I's were dotted and the T's crossed.
Yeah, we only signed the contracts last week, so it literally is hot off the press. So
just like in the Olympics, there's a baton that comes up, and in fact, the baton will come on the 16th from Leeds to Newcastle, and there's a group of us cycling. So I've just said I'll wear a PHA top for that, and we're cycling from Leeds to Newcastle. We're meeting all the transplant cycling teams from all over at the Angel of the North, and then we'll proceed up to the centre of Newcastle, up Grey Street to the monument, and there'll be lots of photo media. So we'll make sure PHA are up there. All right.
I think the PHA sponsoring the Transplant Games is fantastic. It's got so many benefits for pulmonary hypertension, for patients with pulmonary hypertension in the UK, for the Patients Association. There are many potential benefits, both as an organisation and for the future care and treatment of patients with pulmonary hypertension. We know that over the last 10 or 20 years, the numbers of patients treated with pulmonary hypertension, the treatments available for patients with pulmonary hypertension have increased significantly. We know that getting new treatments available for patients with pulmonary hypertension or having them approved on the NHS can be difficult. So anything that raises the profile of pulmonary hypertension as a condition, makes it more in the public eye, can help all of that. And in other ways, Pulmonary Hypertension Association does such good work, but is still a relatively small organisation. To raise its profile is great. Pulmonary hypertension patient numbers in the UK are very small compared with lots of other, even respiratory conditions. So to have that condition on a wider stage will hopefully raise more awareness. That awareness leads to increased fundraising, research, but on the other side, it also raises the public's awareness of pulmonary hypertension as a condition. The more the public are aware of pulmonary hypertension as a condition, they're aware of the symptoms, we can hope that people can seek medical advice sooner to achieve a sooner and earlier, more accurate diagnosis that will let people live longer. If through this we also raise awareness amongst patients with pulmonary hypertension about transplantation, the long-term positive benefits of transplantation, it will take some of the taboos about transplant away from the conversations that we as doctors have with patients. Introduce the option of transplantation sooner and make it more accessible subject so that patients and their families can think about this as a positive treatment option rather than thinking of it as a last resort, which I think is often the case at the moment.
Anyway, now to something completely different in a way, but it actually fits very, very well because this is one of the surgical interventions available in PH, and Natalie's going to talk primarily about PT and some new technology and some new techniques in that. But again, over the 20 years, the surgical intervention in CTEPH has changed dramatically, hasn't it? And Papworth, where I know you've just retired from, he's a world leader in that. So Natalie, I wait with bated breath, literally, to hearing what has happened and what the future is. And as you said earlier, happy retirement. Well, I am hoping as well, we're hoping as well to use Natalie in the future with some stuff with the PHA. So you may be around for a while.
I'll probably be around.
Right, over to you, Natalie.
Thank you. So that one. Okay. Hello. So it's a great pleasure to be here. I can see there's a few people in the room still, so that's good. So I'm going to actually put you on the spot a little bit to start with. First of all, let me just check. Can you hear me? Because I have a quiet voice. So if you can't hear me, just put a hand up and I will try and speak up a bit. So, first thing I wanted to know is there anybody in this room who, as far as they know, and only put your hands up if you feel comfortable with this, but as far as they know, are being considered for a pulmonary endarterectomy or a balloon pulmonary angioplasty? If you're being considered for that, would you put your hands up, please? So one so far, okay. Anybody in here had a pulmonary endarterectomy or a balloon pulmonary angioplasty? So quite a few of you, so that's quite good. Okay. All right, well, sorry, the people who just put their hands up who've had a pulmonary endarterectomy and a balloon pulmonary angioplasty, would you mind standing up, please? So for the people who are being considered for the procedure, these are the guys that you want to go and buy a drink in the bar later, because you need to get their experience. It's very important. Okay, we should take a seat. Thank you. So that looks beautiful, doesn't it? It does from our point of view, but I think Mr. Jenkins, who is the consultant surgeon at Papworth Hospital, took it a little bit far when the first 50 patients, the casts that are taken out of the lungs, the pulmonary endarterectomy, he made them all into a mat. Not the casts themselves, you understand, pictures of the casts, were all made into a mouse mat. And a mouse mat was presented to various people that came to a conference, and it was the most disgusting thing you can imagine. And everybody got one, and everybody was really a bit taken aback, but he thought they were beautiful, so I wanted I'm going to test you a little bit on your A&P in a minute, but this, just to start with, as you see, these are the specialist centres in the UK. Now, this is important because all of these specialist centres send, if you have or potentially have chronic thromboembolic pulmonary hypertension, they will send your imaging to Papworth Hospital. And Papworth, as you can see, is about 60 miles north of London. We're a little bit closer to Cambridge now than we used to be. And there they have probably the best radiologists in the world. And the radiologists and the surgeons and the physicians and other members of the specialist team get together and go through all of the imaging of patients who are likely to have chronic thromboembolic pulmonary hypertension. And they look at that to see if that is a diagnosis they can confirm, and if it is confirmed, what kind of disease they've got, and whether it is potentially operable or whether it's potentially angioplasted. And I'll talk about both of those options as we go along. So, the pulmonary hypertension, I just want you to remember, I know Wendy and Carl went through this very carefully this morning, so now I'm going to test you to see if you're actually paying attention. So, when you breathe in, the air goes into your lungs, and it goes into air sacs in the lungs. And the air sacs are surrounded by what blood vessels? Anybody remember? Small capillaries, yeah? And when you breathe in, the oxygen goes into capillaries, and then it is pumped around the body. So it goes to the left side of the heart, into the left ventricle, and the left ventricle contracts and it pumps oxygenated blood around the body. There's a point to all of this, so just bear with me. So the body uses up the oxygen and it puts waste products back into the circulation. And that can be carbon dioxide and other waste products. So that then is pumped back to the heart. It comes back to the right side of the heart. It goes into the right atrium. It goes through the tricuspid valve to the right ventricle. And the right ventricle contracts and pushes that deoxygenated blood through the lungs. Yeah? When that blood goes back through the capillaries, those gases and waste products pass into your air sacs and you breathe them out. And then you breathe in more oxygen and the whole process starts again. Is everybody clear on that? It's a two-circuit system. Yeah? Anybody got any questions about that? No. In normal pulmonary hypertension, as problems occur in those vessels that occur between the right side of the heart and the capillaries in the lungs, those are the pulmonary arteries, then the pressure slowly starts to build up. In chronic thromboembolic pulmonary hypertension, this build-up of pressure is usually a consequence of a sudden event. So it could be a catastrophic pulmonary embolism that can cause sudden death. So you've had a big clot travel through your heart, travel to the lung, block off a large part of the circulation through the lungs, and somebody collapses and dies. And that is a severe pulmonary embolism. You can also have pulmonary embolism where the clot goes to the lungs and it causes really bad symptoms, and some of you might well have experienced that, and you're admitted to hospital. You might be given thrombolysis, which breaks down the clot. You would be given anticoagulation for 3 months, and then, if all goes well, you will go home. A significant number of people who end up with pulmonary hypertension as a consequence of clots in their lungs have no idea they've ever had a pulmonary embolism. It is entirely silent. So that's worthwhile remembering as well, because just because you've never had a clot in your leg that you're aware of, or a clot travel to your lung, it doesn't mean that you're not at risk of pulmonary embolism. And the reason I say that is not to frighten everybody in the room, but the fact is that we know that pulmonary embolism is a very underdiagnosed condition. And we know this from various trials that have been done over the years looking at people that have died unexpectedly in hospital, where pulmonary embolism was not expected to be the cause, and yet it was found out to be the cause. And this is something that's been replicated at various times over the years. So when the pressure goes up in the lungs, you've got this increase in blood pressure in the pulmonary circulation. And as I say, in pulmonary arterial hypertension, it goes up quite slowly. In chronic thromboembolic pulmonary hypertension, it can go up very fast. Now, if you've got a slow increase in pulmonary arterial hypertension, a slow increase in the pressures in your lungs, your body has a chance to adapt. So over time, the heart beats stronger to make sure that the blood flows through the lungs, and it's still managing to get through. So the heart is a muscle. You work a muscle, it gets bigger, and it gets thicker. So the right side of the heart has to work much harder than it did before. Also, there's other adaptations that can take place in the body. When it's a clot that travels to the lungs, the body doesn't have time to adapt. And for that reason, chronic thromboembolic pulmonary hypertension, if it is not treated, is one of the more quickly lethal forms of the disease. Just to cheer you all up on that one, sorry about that. So we talk a little bit about right heart catheter. The picture on the right there is important. I want you to remember particularly, it's this one, isn't it? Yes. I want you particularly to remember that cutout. That's the left side of the heart. That's where the blood flows out and goes around the body. It comes back into the right atrium, through the tricuspid valve, and into the right ventricle. Right ventricle contracts and then pushes that blood through the lungs. So if you remember that bit. And also, I want you to remember this bit for the echo, because this is also quite interesting for the thing I'm about to show you. You can see here, one of the things we look for when we do an echocardiogram, we want to see how well the right side of the heart is functioning. We want to see if when it contracts, if it's going in quite nicely on both sides. And we want to see if there's any kind of regurgitation. There shouldn't be any regurgitation in a normal heart. When this right ventricle contracts, it should be able to push all the blood through the lungs. It's only if the pressure is so high in the lungs that you actually get a backflow going back through there. And that occurs in pulmonary hypertension. So I'm going to show you this, I hope, if it works. No, it didn't. How do I make the video play? So you can see there, it's showing the electrical impulse that causes the heart to beat. Those are the air sacs in the lungs. Electrical impulse again, but you can see these are the capillaries that surround the air sacs in the lungs. Expanding and going down as we breathe in and out. Now, this is a normal pulmonary artery, and this is what happens in pulmonary hypertension. You can see that this inner lining is slowly getting thicker, and so is this muscle layer. And that is what we would see on right heart catheter when we're actually measuring it. You see that's getting thicker? The intimal layer gets thicker, and so does the muscle layer. And that causes an increase in the pressures as measured at the right heart catheter. Now this is a normal heart, and this is a heart working with pulmonary hypertension. You can see these are the spikes that we would see during the right heart catheter. And you can see here that this heart is functioning well, it's contracting properly. This side, if you look, as this wave gets bigger, as the pressure goes up, the pulmonary artery is getting bigger. You're beginning to see a backflow as the heart contracts through the tricuspid valve. And if you see here, this muscle is getting bigger as the heart is having to work harder. And you can also see here the inner part of the heart, whereas both sides should contract nicely, we're getting what's called a septal bow, and that shows up in the echocardiogram. So you can see your poor old heart's getting quite tired in that situation. So with pulmonary embolism, what happens when this clot goes to the lungs? Under normal circumstances, a pulmonary embolism is a clot that travels to the lungs. As I said, it can either cause you symptoms, or it can be completely silent, or it can, in few circumstances, be catastrophic. Under normal circumstances, the body will clear the clot. Most people, we suspect, that have a pulmonary embolism never know they have one and never have any reason to know. There's no reason to think that we can't fire off small clots quite often, and the body just gets rid of it for various reasons. If we've had symptoms, then we're admitted to hospital, thrombolysis to get rid of the clot, and you're treated with anticoagulation, and again, under normal circumstances, that clot will disappear. For the unfortunate few, about 0.05% of people with a diagnosed pulmonary embolism, so bear in mind that's a diagnosed pulmonary embolism, we don't know how many out there who are not diagnosed. When the clot travels to the lung, instead of the body getting rid of it, it doesn't. The clot sits there, and over time it becomes hard and it becomes fibrosed. So it's not squishy anymore. So a hard fibrosed clot can do two things, basically. It can either break down and become quite thin, thready, and then that forms a sort of a cross web across the pulmonary artery, across the lumen of the pulmonary artery where it is. The other thing it can do is it can form a solid obstruction, and what happens then is that the lining of the pulmonary artery grows over it and organises it into the wall. And you will hear this sometimes referred to as scarring. Now, when that happens, there is nothing we can do. We cannot get to that clot except mechanically through a pulmonary thromboembolic. The other thing is, you remember the slide that Wendy showed this morning of how dense the vascular tree is in the lungs. So it divides and it subdivides and it subdivides, and it's really extremely dense. So when this clot has travelled to the lungs, as soon as it hits a branch point, it breaks and scatters. You get a scattergun effect. So it is never just a clot in one place that we're going to have to address when we go in to try and do something about this. It's always clots that are in several places. Now that's okay from our point of view if they're relatively central. Because although it's causing a big problem, because it's affecting a large part of the lung, it means that we can actually get to them. But if those clots have travelled through the lungs and are sitting more in the periphery of the chest, then that's distal disease, and it's a lot more difficult to get to. And you can see here, that's a bit of a cartoon. It's not normal size. You have to understand this has been greatly, sorry, I keep on thinking this is a pointer. It's been greatly enlarged, but that's what it might look like when it's actually gone in there. So these are the radiological images that we look for at Papworth. This is the kind of things that they would send through to us. So this is a ventilation perfusion scan, or VQ scan. And what this is the patient is given some radioactive isotope to breathe in, and then they are given an injection of the radioactive isotope. This generates two sets of pictures. The first set is when you breathe, you can see the flow of air through the lungs. And then the second set of pictures when you can see the flow of blood through the lungs. And if there's a good match, then the chances are you're not likely to have had a clot that has blocked off some of the perfusion through the lungs. But if it's mismatched, then there could be a chance. This is one of the things that shows us that you might have a clot causing thromboembolic pulmonary hypertension or pulmonary embolism. CTEPH. I'm sorry this isn't a moving image because I think you would have found it quite interesting to see. The little white dots on that image are actually the pulmonary arteries. And as you can follow it through, as you play the image, you can actually see if it breaks off early. Pulmonary angiogram, same thing. I wish it was a moving image, but it wasn't. But if you can see on the periphery, you can see that kind of blush at the top. That's perfusion, as the radioactive image is picked up, of the flow of the blood through the lungs. But you can also see further down that there's some blocking off, say there, and that shows the presence of an obstruction in the lungs. And the other one is an MR pulmonary angiogram. This one is particularly important for the balloon pulmonary angioplasty. You won't be considered for balloon pulmonary angioplasty unless you've had a pulmonary angiogram. So, chronic thromboembolic pulmonary hypertension is one of the most prevalent forms of pulmonary hypertension. 3.8% who have CTEPH will develop CTEPH in the 2 years following an acute pulmonary embolism. Sorry, I hadn't read that bit before. My apologies. 25% of CTEPH patients have no history of an embolic event, so they don't know that they've had a clot that's travelled to the lungs. And this is one of the few forms of pulmonary hypertension where it's actually equal between male and female. So the natural history of CTEPH, lots of patients report a honeymoon period. So it's about 2 or 3 years, possibly, since they had their pulmonary embolism, and then they begin to notice that they're more breathless. And the average age at presentation in the UK currently is 59 years. The youngest person we've operated on was 14, I believe, and the oldest one was 93. So it can also affect almost anybody at any age. Presenting symptoms are the same as any type of pulmonary hypertension: increased breathlessness, exhaustion, fainting, swelling of ankles, legs, and abdomen. And the average survival, if untreated, remember I said it was one of the more fatal forms of pulmonary hypertension, rapidly fatal if it's not treated. And it's less than 2 years, which is worse than many types of common cancer. And again, this is one of the awareness-raising things that we're quite keen to get across when we're commissioning services. Pulmonary endarterectomy is where they can core out that old fibrous clot, or the old fibrous clots, where possible. And the reason it is the treatment of choice is because it is potentially curative. It can cure you of pulmonary hypertension if we can do it, and if we can do it successfully. But there are certain criteria that you have to meet before we can offer it. So as I said, the imaging will have come to Papworth for the Papworth team to have looked at. The surgical treatment depends, well, if we offer it to you, it depends on where it is, whether the obstructions are in the lungs. And this gives you rough ideas. Again, it's a cartoon, but if the clots are relatively central, then that becomes operable, versus if the clots are relatively out towards the margin of the lungs, and then that's distal. We might, in the old days, when we first started doing pulmonary endarterectomy, the clots had to be very central before we would even consider it. Now that we are a lot more experienced, and Papworth is doing many more of these operations, we'll consider doing people with mixed disease. So then the question is, if we take out some of the clots, but we can't get to the others, are we actually going to improve quality of life, and are we going to improve survival? Now, if we are likely to improve at least one of those criteria, then yes, they will probably offer a pulmonary endarterectomy. But they will have to have at least one of those criteria. So they won't take out clots if it's not going to make any difference. It's not an insignificant operation. They're not going to do it for fun. Now, balloon pulmonary angioplasty, this is something that we started doing in 2015. We started doing it at Papworth, and it was commissioned by NHS England last year. We've been commissioned to do 30 patients. And what this involves is where the clots are more out towards the periphery, we can sometimes still get a wire through to them. And you remember when I explained about a web versus an obstruction? So if there's a web, we can sometimes get a wire in. And if that's the case, then we can open up the balloon on the wire, and we can actually push that material into the side. Remember, it's not a squashy clot anymore, it is hard fibrous material. So you can push it out, and then it stays out. And you've opened up the flow of blood to the lungs and hopefully brought the pressure down and improved the situation. That, very simply, is balloon pulmonary angioplasty. It will not be offered if you are suitable for surgery. And it won't be offered even if you don't like the idea of surgery and think you prefer to have a balloon pulmonary angioplasty. It's the first thing that is commissioned is pulmonary endarterectomy, because that is potentially curative. This is not curative. There's too many variables involved with this. But it has significantly improved the situation for many of the patients that we've done. We've done around 50 patients now, have had balloon pulmonary angioplasty. Very good outcomes for most of them. They've all bar one had an improvement on their hemodynamics. That is the figures that show that the pressures have come down in the lungs and the action of the heart. The vast majority of patients have experienced improvement. They feel much better as a consequence. But a very small minority, I think 1 or 2 patients, haven't actually experienced any improvement at all. Pre-op procedures, coronary angiogram. If you are over 40 and you have risk factors for coronary artery disease. So if you've got, if you're overweight, if you have diabetes, if you have COPD, if you smoke, that kind of thing, if you don't exercise, then we would do a coronary angiogram. If you're over 50, we'll do one anyway. If you do have coronary artery disease, then we'll do you a 2-for-1 deal. We'll actually do the coronary bypass graft at the time that we do the pulmonary endarterectomy surgery. So it's not a contraindicator, it just means that we're getting them both done at the same time. And the surgical outcomes for pulmonary thromboembolic, 70 to 85% of patients will have an abrupt, significant decrease in their mean pulmonary artery pressure, together with an increased cardiac output, so the heart is working better following pulmonary thromboembolic. 5% of patients, their mean pulmonary artery pressure will remain elevated, but their heart will function better and they'll feel better. And around about 10% of patients remain very ill. Now, there's some reasons for that they don't experience any improvement. There's various reasons for that. It might be, although the imaging is very good at giving us a very good view of what's going on, it's not perfect. And at the end of the day, when they go in, sometimes they find surprises when they get in there as to the distribution of the clots. And the other thing is, when you get in the clot out, some clots are stickier than others and more difficult to get out than others. For the vast majority of cases, they are very, very happy with the clearance that they get with most patients, but very, very occasionally, the clearance is not so great, and the patient can be left with more of a residual disease than we expected. The other thing that can happen is that when you have a clot and you've got blood flowing towards that clot, and it becomes very turbulent, and if you have turbulent blood in a pulmonary artery, it can damage the pulmonary artery, the lining of it. And if you've damaged the lining of the pulmonary artery, that can set up something called a vasculopathy, which means that you get a permanent damage in that artery, which can lead in itself to pulmonary arterial hypertension. So that, again, doesn't happen very often, but it is something that can sometimes affect the outcome following pulmonary thromboembolic. Let's say around about 10% of patients, all told, might not have a good result following the surgery. Lifelong anticoagulation. People ask me about warfarin versus the novel anticoagulations that are out there at the moment. At the moment, there's not really much evidence to say that the NOACs do a good job or a bad job with pulmonary hypertension. But we do know that for the thromboembolic form of the disease, it is really important that you remain anticoagulated and that you remain well anticoagulated. So if you're having procedures, it's necessary that you are covered with low molecular weight heparin injections if you have to come off your warfarin. The advantage of warfarin is that we can check if it's doing a good enough job in keeping you anticoagulated, and we can't do that with the NOACs and the DOACs. So it's important in most cases for patients with thromboembolic pulmonary hypertension to be on warfarin, but the jury's still out. And there are some people who come to us for assessment for PTE who are on rivaroxaban or whatever and are very happy to stay on it. And, it then becomes a question of patient choice. And also some people are too frail. They don't like or can't get backwards and forwards to get blood taken to monitor the INR for the warfarin. So under those circumstances, some coagulation is a lot better than none. So the benefits of pulmonary endarterectomy and of balloon pulmonary angioplasty: an improvement in the symptoms, better quality of life as measured by emphasis 10 and by CAMPHA. So we have the objective evidence to put in front of the commissioners that yes, this works. Reduced disease progression and a prolonged life. The oldest person, as I say, we've done is 84 and is still going strong, which is very good news, given that was quite a while ago now. We did a study which looked at the difference between patients who were young and had pulmonary endarterectomy and patients who were older, who might be more expected to consider just having oral medication therapy rather than go through a very significant operation. And we looked at their quality of life and other outcomes, and their quality of life far exceeded any outcome related to just taking medications. So even if you're quite elderly and you're considering pulmonary endarterectomy, it's well worthwhile giving it a consideration. So, pulmonary endarterectomy, potentially curative, improves the quality of life in patients with CTEPH in the vast majority of cases. Lifelong anticoagulation is vital to prevent the further risk of embolism. What I was going to do now, if you want, this is taken from the One Show. Has anybody seen this? Anybody remember it? Yeah. Have you all seen it? Okay. I will put this on if that's okay. It will take about 10 minutes. And what this was a patient who went through pulmonary endarterectomy. Now, for the patients who are considering pulmonary endarterectomy, just to mention that because the presenter is quite dramatic and she refers to it in terms of life or death, so it can be a little bit anxiety inducing. But you have to remember that our outcomes with pulmonary hypertension, first of all, we have 95% success rate with pulmonary hypertension and with the pulmonary endarterectomy. And, you have to remember that most people's experience is very smooth. So can we play this?
Evening. Right now, though, we're embarking on another incredible journey.
Yes, but this time a much more personal one, made by a young mum called Sue Buckle. Sue faces surgery so complicated that only a few hospitals in the world can carry it out, but it's her only chance of survival.
29-year-old Sue Buckle has everything to live for.
I tried for Amelia for 3.5 years. I had to lose quite a lot of weight and had some medical help, hormones and different things to conceive. But it was amazing. Best thing I've ever done, definitely.
But Sue's health deteriorated rapidly after Amelia was born.
Sue came out of hospital and just couldn't get out of bed, and I just said, this isn't right. I know it's you go on adrenaline when you've had a child, it keeps you going, but I knew something wasn't right. And she came to answer the door to a health visitor and lost her breath, and that was when we took her into hospital because that wasn't right.
Sue has developed pulmonary hypertension, dangerously high blood pressure in her lungs. She's now permanently attached to an oxygen tank and barely able to lift her own daughter.
I have my days where I'm unbelievably frustrated. I just want to shut the door and just be a mum and say, I'll do it on my own. And there's been a couple of mornings I've tried it and regretted it. And that's made me probably even more angry as well, because I want to do it. I want to do it on my terms.
But the surgery that could save her is only performed at a handful of hospitals in the world. It's incredibly complex. Without it, Sue will die. The arteries in her lungs are clogged with blood clots, putting unbearable pressure on her heart.
In the scan here, Mrs. Buckle's lungs, in the upper lobes, the branches are reasonably smooth and relatively normal, but in the lower lobes, the branches are narrowed and blocked in lots of places.
So that means the right side of the heart has to work harder to get the blood round.
That's exactly right.
What happens in the long term?
Well, as the right side of the heart, which is designed to pump against a low pressure in the lung circulation, initially it tries to compensate, but eventually it gets bigger and more dilated and less efficient, and eventually people get right heart failure and become extremely unwell and eventually unfortunately die.
Sue knew her chances of surviving more than a couple of years were slim.
The more I read, the more terrified I was at the condition, and the more I realised that I'd had a beautiful baby girl, and would I see her to grow up? I wasn't sure, and it was just devastating. And I just thought, my life has got a time limit.
But Sue has been offered a lifeline by Papworth Hospital near Cambridge. It's the only centre in the UK to perform the surgery that might cure her. But it's one of the most difficult heart and lung operations undertaken anywhere.
And unfortunately, the pulmonary arteries are relatively inconveniently placed in the body because they're in the middle of the lungs, and usually they have 5 litres of blood every minute flowing through them. So for this operation, we have to drain all her blood out of the body into the heart-lung machine. So I get a very good view, but for her, there's no blood flowing at all.
The only way to keep Sue alive with no circulation will be to shut down her body and brain, reducing her temperature by nearly half to just 20 degrees. It sounds like you're almost putting her in suspended animation, if you like.
I think that's a good term. It's true. It's like a short-term hibernation. If we asked someone to come and examine her, there would be no signs of life. There'd be no pulse, no blood pressure, no respiratory effort, no reflexes, no brain activity. So it is like a short-term hibernation or suspended animation.
It's the closest to death a human being can come and still be revived.
Having Amelia and being so little and the operation is so huge, it is very daunting. It's a lot to take in, but I hope that the other side of it, I can be the mum I want to be and be just me and her, just be her mum, and just the two of us, really. It'd be fantastic.
And later on this evening, we'll see how Sue's operation went.
Okay, back to Sue now.
Yes.
Today, Sue Buckle is having one of the most technically difficult heart and lung operations performed anywhere in the world.
The operation is massive, and this is the calm before the storm.
Sue's rare lung disease, pulmonary hypertension, was diagnosed just a month after the birth of her daughter.
Just looking forward to taking Amelia for walks, pushing her in a pushchair, rocking her to sleep if that's what she needs, being able to hold her for longer instead of having to just pass her on and say she's crying and I'm tired.
Sue's lungs are clogged with blood clots, which are putting unbearable pressure on her heart. The intricate surgery that could save her will involve putting her into a state of suspended animation, so her body can be completely drained of blood. It's her only chance of seeing Amelia grow up.
Over 90% of patients after this operation are alive at 5 years. Over 2/3 of patients, it can offer a complete cure. There's a good chance she hopefully will get back to a very good quality of life.
It takes nearly an hour to open Sue's chest. They're going to reach her lungs through an artery in her heart. A machine will take over the work of her heart and lungs.
The machine takes over the breathing and the circulation of the patient. So the blood comes out of the body, bypasses the heart and lungs, goes into the next machine there, and then comes back oxygenated.
In most cardiothoracic operations, that would be enough to allow for surgery, but not in this one.
Mr. Jenkins' operating field is probably a hole about an inch across. We need to switch the heart-lung machine off because if we didn't, he'd always have a blood flow coming through, so it would actually impede his vision.
The only way the team can do the operation without killing Sue is to slow her metabolism down to a virtual standstill.
We need to cool the patient slowly to about 20 degrees, and then that gives us the safe period of 20-30 minutes when we can drain all her blood out and have a very good view to do the actual operation.
Sue's blood is very gradually chilled as it runs through the bypass machine, reducing her body temperature to nearly half its normal level. She'll be entering a state of suspended animation.
It's all designed to try and protect the brain from the periods where we switch the pump off completely.
If you didn't do that, how long would it take for her to be brain damaged?
At normal body temperature, like you or I now, 3 to 4 minutes, and already we would start to see irreversible brain damage.
Okay, so Nick, you can stop the circulation now and drain out, please.
This is an extraordinary moment. The heart-lung machine's just been switched off, and all the blood is draining from Susan's body right in front of our eyes. This is as close to being dead as you can get, and still be revived. They've now got just 20 minutes to tease out the blood clots before her organs start to fail.
There's no way of knowing how easy or difficult it's going to be. Hers is actually quite stuck. Gently wiggling these out.
They've managed to remove the major blockages from the right side, but time has run out.
So we just reached 20 minutes. But I think we've done enough to clear the main areas there, so we're reasonably satisfied.
Sue will now briefly go back on bypass to refresh her brain and body with a life-saving cycle of blood. Then, Mr. Jenkins will have to start all over again on her other lung.
We'll only get the final proof when we come off bypass and see what the pressures are like and see how she is.
After 7 hours, the operation is nearly over. Sue's body has been returned to normal temperature and her circulation restored. Mr. Jenkins is pleased with the results.
We're a little bit worried that she might have partially perforated into the lungs, but she hasn't. And it's looking, for this stage, it's looking pretty good. I think she's going to be all right.
Sue will now go into intensive care. If her recovery goes well, she could be home in a couple of weeks, with a new life ahead of her. When I was a medical student, this was the stuff of science fiction. From my perspective, this is as close to a medical miracle as you can get.
So how is she? Well, Sue is still recovering and not quite well enough to travel yet, so we went to her. Have a look at this.
Hi, Alex and Chris. I just wanted to give you an update on how I'm doing. I remember very well the first breath after my operation, and taking quite a deep breath and it being really quite exciting that I could breathe on my own. Coming home was incredible. It was just amazing to see Amelia, who'd been here waiting for me to come home, having a cuddle. Now I've had my operation, I'm able to dress Amelia and change her nappy, all those things that some parents would go, oh, bleh, mundane things, but to me, everyone is so special. And pushing her in a pushchair is just lovely, and not having an oxygen cylinder and being breathless, just being able to do it on my own is incredible. I just want to say a humongous thank you to David Jenkins and everyone that helped look after me at Papworth. Before the operation and being told my life expectancy wasn't particularly great, I viewed everything, birthdays, Christmases, Mother's Days, as countdown. You know, this might be the last one. And now it's incredible that I haven't got that over my shoulders. I can't wait for Mother's Day. You know, I can enjoy it like any mum can. Just being able to go out for the day with my family, it'll be a lovely day. I'm really looking forward to it.
Oh, thanks, Sue, and we hope you have a very happy Mother's Day. David joins us now on the sofa, the surgeon who operated on Sue. Is she cured now, David? Is that it?
Yes, she should be. She's had a really good result. The pressures have come down and she needs to stay on blood thinners for the rest of her life to stop further clots, but she's pretty much cured.
First of all, David, well done, by the way. A little round of applause. Thank you very much. What a job, saving people's lives. And this procedure was pioneered in America, but last year, did we do the most operations in the world?
That's right. The University of San Diego in California started all this type of surgery and this operation. We've been doing it in the UK since the mid-90s, and last year we did 130 of these operations, which actually was the most in the world now.
So you're pretty good at them now?
We're pretty good now,
Congratulations.
yes. Yeah.
What was the first one like? Were you nervous?
Not from the technical procedure. I think more the responsibility for the patient, but cardiac surgeons are reasonably confident, so when you're actually doing the procedure, I can focus just on that. I'm not worrying about her baby and the family. Afterwards, I think one feels the responsibility, but at the time, it's just a technical exercise.
Yeah.
All right. Well,
great
thanks
job.
so much.
Yeah, great
Thanks for
job.
being here.
Thank you, David. This evening, we are following the start of the One Show 1000.
Much we have.
That's impressive, isn't it? Yeah, always like that. We tease David on that one, first of all, because what they don't show is that he has to stand on a stool because he's so short. And the other thing is that on the day that he went for filming, they came and collected him in a car and he had to be taken off for his makeup. So that was quite nice as well. So we do tease him over that. So that is pulmonary thromboembolic, CTEPH, and I've touched on balloon pulmonary angioplasty as well, and the need for lifelong anticoagulation. Has anybody got any questions? Yeah.
How was the decision made whether I'm warfarin or rivaroxaban?
The decision at Papworth is straightforward. If the patient can take warfarin, we put them on warfarin. Some patients will come to a specialist centre from a district general hospital who will have started them on rivaroxaban or whatever. Increasingly, these decisions are being made by non-specialist centres because that medication is cheaper to administer. Patients on warfarin have to go for regular blood tests to make sure that the warfarin, and it's inconvenient for the patient, and you have to have test strips and all sorts of things, and whole departments are devoted to maintaining patients on warfarin, and it's an expensive way of treating anticoagulating a patient. So it's seen as more cost-effective to put patients on the NOACs and the DOACs, and they are effective anticoagulations for the vast majority of conditions. It has to be said, they're very good, but for patients with thromboembolic pulmonary hypertension, on the whole, Papworth and the other specialist centres prefer warfarin when we can. But as I say, you do get some patients who can't travel to get INR taken or who won't, in which case it's more important that they're treated safely. Because when you give warfarin, the effect can vary dramatically, whereas with the other medications, it's set doses. So you have to be relatively sure that your patient is going to be reasonably compliant, get regular checking, and know that the medication is the correct dose that they should be taking.
I mean, I think I know from clinical practice in Sheffield, you use the drugs you're most familiar with. So we are most familiar with warfarin.
Yeah.
So and that's when you have the most secure. The problem is those patients who are unstable on warfarin.
Yeah.
And then
And that's also a problem. So many of those patients end up, well, I say many of those patients, there are a minority of patients. Most people can take warfarin without any problems. But occasionally you will get patients who end up on long-term injections into their tummy, which again is, it's not the best way to proceed, but it's a very effective way of proceeding. And if patients tolerate that, and there are some out there that would prefer that rather than take the risk of being on a NOAC or a DOAC. So it varies. I think things are changing, and I think eventually warfarin I think will be phased out, but not yet. And there's no evidence yet to support safe use of NOACs or DOACs wide scale, large scale in thromboembolic pulmonary hypertension.
What do you think, Natalie? I know one of the things that does cause anxiety, and I mean, this is not necessarily the surgery itself, but Papworth's been moved now from where it is to this bigger hospital. Do you? I mean, is that purposefully a good thing? Do you think, or was Papworth at risk because it was on a limb? I mean, there's been a lot of discussion, and we see this with rationalisation of services. That's what I'm really getting at.
Yeah. So is this going to be a good thing for patients as opposed to a bad thing for patients? I think unequivocally it's going to be a good thing for patients. For a few, it's going to be a bit more inconvenient and slightly more expensive to travel to the centre of Cambridge. That will change, I think, over time as more infrastructure is put in place with buses and trains and things. There's going to be a train station very close to the hospital. What we gain with the new hospital is we are not Addenbrooke's, but we are close to Addenbrooke's. So if we need to access Addenbrooke services for any of our patients, bearing in mind we're cardiothoracic, we don't do anything under the waist. So if we need to send patients for anything related, we're much, much closer to an excellent hospital where they can be seen and treated and diagnosed. Something else I was going to say. Yes, capacity will increase at the new hospital. So hopefully we'll be able to do more pulmonary endarterectomies, and we will certainly be able to do more balloon pulmonary angioplasties, which is, now that we've been commissioned as an expert centre to do that. I suspect eventually there will be a second centre to do balloon pulmonary angioplasty, because I think that the numbers of patients coming through for that are going to go up exponentially. We've seen a 60% increase so far year on year since 2015, and that's right at the beginning of this particular service, so it's going to be interesting to see what happens with that. But there's greater capacity at the new hospital.
You can determine CTEPH through radiology.
Yes.
Knowing that pulmonary hypertension is all about the high blood pressure in the lungs, and knowing that they do the right side catheterization to determine pulmonary pressures, I'm quite surprised that on the list of things, you don't see the radiology side of things, the CTEPH. I'm talking about in terms of cancelling out why individuals have pulmonary hypertension.
All patients that go to a specialist centre, their imaging is scrutinised very carefully, and the right heart catheter as well is a diagnostic procedure. So you've got a very clear idea that this patient is likely to have CTEPH by the time their imaging comes to Papworth. So the specialist centres out there, they're expert centres, there's no two ways about it. They know what they're looking for when they look at imaging. If somebody has CTEPH and they recognise that somebody has CTEPH, or if there is no obvious history of CTEPH, but there is a history of clots that have travelled to the lungs, or if there is no obvious other cause that they can see that the patient has for pulmonary hypertension, then as a fail-safe, that imaging will be sent to Papworth.
Oh, they automatically go to that?
It's rare that we will miss a patient. It's very rare. It's interesting, when the specialist centres were commissioned, which was back in around about 2001, 2002, and we started... There were other hospitals that had patients with pulmonary hypertension, and they started to be required to refer those patients into the specialist centres. And there was a flurry of referrals through to Papworth as a consequence of that, where patients who had not been under the purview of a specialist centre suddenly were and were found. And it worked very well. Specialist centres are very good at picking it up.
Reassuring, isn't it? I mean, I think it's one of the things just talking about specialist centres per se. That I know in Sheffield we're a general PH centre, so we have no speciality particularly. But we, of all the referrals we get, and we see the most number of people in the UK purely because Sheffield is central to the UK. I mean, okay, we're the best, but it is purely because of where we are. It's geographically, we've got biggest access to population. So you'd expect Sheffield to see the most. And about 20% of people who get referred to us, does this individual have PH? We will say and actually rule out PH. So you should have a high index of false referrals. Otherwise, you're missing people, if that makes sense. So about 20% is about right in specialist care. I think that you don't just say, oh no, they haven't. You try and come up with a diagnostic decision so the patient in themselves can be treated. And I'm sure it's the same at Papworth.
The same thing happens with the patients that are referred through from the specialist centres, because if there is any question, then that imaging gets sent to Papworth. So we have a large proportion of them coming through, a significant, around about 40%, where actually we will say there's a bit of CTEPH or there might be mixed disease or whatever, but these patients are not suitable for pulmonary thromboembolic or other interventions from Papworth. So there's quite a few patients that come through to us and we will say, no, there's nothing we can do here. But the point is that they're checked.
Okay, so we're more or less bang on time, 4 minutes early, which is good. It's been a long day, but it's only part of the day. I know some of you older faces looking a bit haggard now, but you want to have a bit of a kip, and then I'll see you down about 8:30. See you down at 6:30. Ready for dinner and a bop. Are you around, Natalie? Are you ready for a dance?
I'm up, yeah. Oh yeah, I'll be there.
Yeah, so it's been a good day, but it continues. So use this as say 6:30, so a couple of hours. It's all tarted up, as it were. I've got a new. I've told you about the new shirt. I'm quite excited about it. It's nothing. It's quite boring, really, but I really quite like my shirt. I just like it. So, and I want you lot to like it. I want you lot to like me, actually. That'd be quite. I have had the mickey taken down to me quite a lot today, which has been unfair. Not from yourself, but from some.
You just didn't hear me.
Yeah. So 2.5 hours, and any comment. We're about and around. If you want to. That's what we're here for this week, and I'm really grateful to people like Natalie and to Carl and to Wendy, etc., from a chair of the PHA, that you've given up your weekend for nothing, for free, etc., for to share your expertise. So, be gentle with them, but don't forget to thank them as well. Okay.